Welcome to the Perspectives on Healthcare podcast, where members of the medical community from different roles, venues, and locations share their unique perspectives on quality healthcare, its future, and how to improve it. Now, from the Your Keynote Speaker studio in Pittsburgh, Pennsylvania, here is your host, Rob Oliver.
Thank you and welcome. I appreciate you being with me today. My guest is Justin Bethany. He is a nurse practitioner with a specialty in psychiatry, and he is out on the West Coast in Oregon. He is also a member of Generation X. Justin, welcome to the podcast.
Yeah, thank you for having me.
Absolutely. So can you tell me a little bit about yourself and your role in healthcare, please?
Sure. Well, I appreciate the Generation X. I snuck right in. I was the last year. And I like to identify with my fellow Gen Xers. So I'm Justin. I attended and graduated from a Master's of Science in Nursing about 12 years ago, and that helped me become a nurse practitioner. And then the specialty I chose was psychiatry. So since that time, I've worked in some inpatient, but mostly outpatient, lots of different clinics over the last 12 years or so. And now I have my own private practice, outpatient, where patients come in for office visits. We work on mental health, prescribing medications. I offer more time for therapy. And then sometimes we look inside the body, do some functional medicine type assessment to see if there's any other stones we can overturn, to see if there's blood sugar issues or gut dysbiosis, chronic inflammation. If we can attend to those issues, it could further help the symptoms, mental illness symptoms. And so that's my practice now in Bend, Oregon.
Okay. So it sounds to me like you're kind of combining three areas of practice. You've got the medical side of things that you're looking at, the medications that can be prescribed. You have the therapeutic side where you're talking to your patients and having them share their thoughts. And then you've got the food and nutritional side of things to look at what else is going in the body. It's kind of a holistic practice, which you take that, put it all together, and add the fact that it's coming from a nurse practitioner, I would guess is a bit of a rarity.
Yeah, I think so. Actually, that's exactly my practice. You described it perfectly. Here in Bend, Oregon, functional medicine began up in Seattle with a bunch of doctors 25 years ago. Mark Hyman and Jeffrey Bland and all these guys. And so I think in the Northwest, naturopathic doctors and functional medicine had already kind of taken off. So when I moved here in 2020, there were a few other people like myself here. I grew up and lived on the East Coast as well, and less so out there. It's kind of more traditional medicine on the East Coast, I'd say. Yeah, I think you're right.
Yep. It's funny because not only do I talk about where folks fall on the generational scale, but talk about where they come from and where their practices are located. And what you said fits exactly into this, because I'm out in, Pennsylvania, more East Coast, you're on the West Coast, and there's a definite difference in the way that practitioners look at patients and the way that individuals approach their care, even I would imagine in the expectation of patients, where on the West Coast you have people who are more open towards non-traditional treatments as opposed to more traditional expectations when it comes to the East Coast, maybe the Southeast, those kind of things. So interesting. Let me ask this. What does quality healthcare mean to you?
Yeah, I really like how you asked this question of all your guests. I thought about it and I broke it down to solving the problem and doing no harm while you're solving the problem, or whatever you're doing to solve the problem. People come because they're suffering, and good healthcare solves the problem, either symptomatically or, if you have a really good treatment outcome, like a resolution.
Yeah. And I think it's interesting what you just said, and that is solving the problem. But solving the problem doesn't always mean removing the diagnosis. have I properly understood what you said?
Yeah, well, some things are breaking and some things are broken. So if you broke your bone, you would need conventional medicine and a cast and the typical what a surgery if you needed that, or you just needed the straight up solution there. If you have, you're pre-diabetic, then it's breaking. It's not quite broken yet, but we want to intervene. We want to put our hand out there and stop the process and reverse it. So depending on the problem, depending on the person, depending on the person's resources and energy and wherewithal and motivation, I think there is a lot in healthcare. There's a lot of choice in the solution. Some people are ready to do everything. Some people are not ready to do everything. Some problems have gone so far where we can just do symptomatic things. Some problems are just beginning or in the middle of their course, and we can really work hard to reverse it. But again, it depends on the patient and what they want.
Yeah, and I'll just key on something that you just said, and that is you mentioned it from a symptomatic perspective. And so to me, I think it sounds important to know what the patient views as the problem that they're looking for you to solve. Because sometimes, you mentioned you have a broken arm, so you put a cast on it and you heal that. Other things that people are dealing with are things that are not going to heal, but things that need to be managed. So in that situation, people who are dealing, let's say, with chronic pain, so you're not going to be able to solve the problem, but you're not going to be able to cure the pain, but you're going to be able to help them manage that, or have people who are dealing with mental health issues. And yes, you want to help them to grow through those, help them to recover from that. But sometimes it's more a management of what is going on than the desire to just solve all the problems. What's your response to that?
Yeah, I agree. I think the same could be true for the same one person, the same individual. Sometimes, mostly, new patients will come to my office and get in and sign up. And, in the first assessment, it uncovers how this is the 11th hour. You didn't come last month or last year when there was an opportunity and there was plenty of symptoms that would warrant you to come. Things got so bad it's the 11th hour. So when it's the 11th hour, then symptomatic treatment, which a handful of different medications, more frequent therapy, helping people get their sleep back on track. There's some symptomatic right now fixes that we can do. But for that same person, over time, when things cool down, then there's those longer term, more focused on the resolution interventions, like deeper therapy, maybe weaning off of medications, pushing them to improve their lifestyle even more, sleep, diet, exercise, all that stuff. So yeah, I agree. And I think it could happen for the same person, both symptomatic and the other.
Yep. And the key to that is meeting the person where they are and providing them with the intervention, the support, the tools that they need right now, with an understanding that those may change over the course of time. Very interesting. Okay. Can you give me an example of quality healthcare?
Well, I guess for myself, I'd have to give you the example for myself. A number of my patients have been diagnosed with bipolar disorder, and with good fortune, with a lot of hard work, with a lot of motivation from the patient, a handful of these patients have been able to taper down, taper off, and stay stable without medication through a lot of work. The three we mentioned, medication was a piece for a time. Looking inside the body, we did some of that stuff, blood sugar balances, taking care of the immune system. With bipolar disorder, you want to make sure that you go to sleep at night. If you stay up past your bedtime, you stay up all night, that can really open the door for a manic, phase to kind of enter, or an agitated phase or a depressive phase. So you want to take care of that. So, we did all those pieces for a handful of these patients that I had. And it took a long time, a lot longer than they wanted it to take.
Sure.
But, we kept focusing. They were patient. They were motivated. It was collaborative, and it was successful. So, yeah, I think that kind of covers a lot of the metrics that we described earlier of what goes into quality.
Yeah, and a lot of times the medications that treat people with bipolar are really, they almost, bipolar has highs and lows. And when they go on the medication, it takes away the highs and the lows, but it leaves you with a very bland experience of life. There's no excitement. There's no downs, but there's no ups. And so being able to get off of those medications is going to provide a bit of a richer life experience for them. Have I mischaracterized that, or what's your thought there?
Yeah, there's a little nuance. And there's an important distinction between mood shifts and then emotional reactions. I mean, one of these patients, we were in my office and she saw her ex's car drive by my office window, and she had an emotional reaction because it was a difficult relationship. And she said, "You see, I'm bipolar," because she was reflecting on how her mood suddenly changed.
Right.
And I helped to say that, that's not necessarily what bipolar is. That's not a mood shift. That's an emotional reaction that's like well within the normal range of living life. We should slice and dice that a little bit. And we did. And, she was one of the patients that was successful with the, being able to get off medications and remaining stable and not having mood shifts. So I think that there's a little nuance. If you take medications, they say in medicine, and it's a good saying, the poison's in the dose. If you're conservative as a prescriber, if you're conservative as a patient, you'll probably take on higher doses just to make sure. Kind of set it and forget it. And I think there is a cost benefit there with some emotional numbing and emotional flattening if the doses are a bit too high or higher than is needed.
Okay.
Every case is different, but that could happen more on the extreme end. Sometimes psychiatric medications do truly give people their life back at the least effective dose.
Got it. Yep. And I want to follow up on one other thing that you had mentioned. You talked about somewhat personal responsibility when it comes to the recovery process, where people are making sure that they are getting enough sleep, they're going to bed at a decent time, how do you motivate patients to buy into that personal responsibility? Because we live in a society that many times is give me a prescription so that it will fix me and that I don't have to make any personal sacrifice or hold any personal responsibility in that.
Well, yeah, I think being human, myself included, that resistance, that pull to eat cookies at night and stay up late and watch TV and not exercise, not today. I mean, that pull is always there. And so all of us have to work against that. It's just part of being human. But the answer to your question is easy. It's education, patient education, medical education, psychoeducation. People don't come to me for recreation. Mm. And when they come to me, patients tend to put on their best face, bravest face, maybe hold back some things. So they seem fine, and they are fine to some degree, but there's something going on that's bad enough for them to want to go through the uncomfortable process of coming to talk to me.
Got it.
So I try to make it comfortable. And then I also try to educate and label in healthy, effective, non-stigmatized labels. Like, okay, this sounds like major depressive disorder, or this sounds like generalized anxiety disorder, or I think you have ADHD. Let's look into it. And the education is just immediately flows into motivation for most patients. I mean, without the education, it can be too much of a one-on-one doctor versus patient type of thing. And a lot of two ships passing in the night type of situations.
Got it. Okay. What do you wish people understood about your role in healthcare?
Yeah, that like much of what we talked about today, that it's collaborative. Some patients that I've seen, many actually, I get the sense that they have the mindset of, I don't know, doc, what do you think? Mm. And that's okay. I mean, that's kind of, in some ways that makes it easier because, I can just do a treatment plan and they'll be compliant because they hold me in authority.
Right.
a medical provider. But then again, there's something missing there with the what do you want, and how are we going to, what are you ready to sign up for? What are you ready to change? All that stuff. And so and there's so much that I don't know about people. It's the stuff I don't even know about myself. So it has to be collaborative. And I wish both patients and doctors would have more of a sense of that.
Excellent. Yeah, everybody's got to get out and take a look at their Joe Harry window, right? So, all right. What excites you about the future of healthcare?
Oh, that we're careening off the edge.
Okay, tell me more.
Yeah, well, someone I follow recently is Callie Means, and his sister is a doctor, and they just wrote a book. They just released it, and he's been doing interviews, promoting, and he's influenced by functional medicine. He talks about, he's got all the statistics down on by the year 20 something, all of us are going to have diabetes and cancer rates and suicide rates, and he even kind of points to some of the harms of SSRIs, medications that I do prescribe. I prescribe them very deliberately, but they are overprescribed. I agree. And so he talked about there's a 40% of the budget of the federal government will be dedicated to diabetes by the year 2040, something like that. We are headed for a crisis with healthcare because it's subpar, it's suboptimal. People don't like it. It's not really solving the problem. It's just kind of keeping you sick in a way. And then he makes this argument pretty well. And so I can't wait for, we're falling asleep at the wheel and we're careening off the road, and I'm waiting for the steering wheel jerk back to rationality.
Got it. Yeah. And there's a difference between not being sick and being healthy. And I think that's some of what functional medicine looks at, and some of that nutritional element where it's more about creating a healthy lifestyle instead of just trying to keep your nose above the waterline of avoiding being sick. So interesting. All right. Last question for you. What is one thing medical professionals can start doing today to improve the quality of healthcare?
Right. Well, so, a patient walks in and they hold me at too high of an authority, and they say, I don't know what you think, doc. And I don't know. And I kind of like that, and I kind of don't like that. And I want them to take the reins, and I want them to find their own internal motivation, their own reasons. So that's in mental health field, that's motivational interviewing. Okay. Motivational interviewing is brilliant and simple. And it does two things at once. It helps to find the patient's motivation, and then it teaches the provider about how the patient thinks, what's important to them, how they make meaning of things, and the little wedges where we could nudge them in a positive direction. So everybody needs to learn the art of persuasion.
Okay. Do you think sometimes, and this is a loaded question, I guess, not only do patients hold medical practitioners in too high of a regard, sometimes medical professionals hold themselves in too high of a regard, and they're not willing to do the collaboration because they're the authority and they're the ones. And so sometimes there needs to be, we all need to be on the same page. It needs to be a collaborative effort, and both sides need to listen. What's your reaction to that?
Doctors, when we're discussing doctors, it's like a pejorative term, like, doctors.
Right.
And I don't feel that way about any medical provider. I mean, they sacrificed, they went to school, they took on debt to help people. And that it's, I'd make the distinction that it's the healthcare system. The stat about, the primary care doctor only allows the patient to talk for 13 seconds before they have to cut them off, because of, if you take a look at their schedule, it's jam packed and they have people, it's crazy. And when it has to be so concise, doctors are left with nothing but their authority to make a decision, to make a treatment plan. They wouldn't even write it out, but they just say, okay, take this med at this time and come back in this much. And because it has to be quick, it really narrows in on that authority type relationship, which is too bad. I mean, for myself, here in Oregon, I created a practice where I see people for an hour, no matter what.
Got it. Yeah. But I think it makes a lot of sense. And at the end of the day, what I'm hearing you say is sometimes it's the system that creates the issues instead of the people. So good. Listen, thank you so much for joining me today. I appreciate you sharing, and I respect your perspective on healthcare.
Thanks for listening to Perspectives on Healthcare. Visit perspectivesonhealthcare.com to learn more about Rob Oliver or to subscribe so you never miss an episode. If this podcast was valuable, we'd appreciate a review on iTunes. Or if you tell a friend or coworker about the show, that would be helpful too. Join us again next time for more Perspectives on Healthcare.